My name's Dr. Sam Morgan. I'm working as a Menopause Fellow with the Training Hub and really pleased to welcome you to this Training Hub webinar for primary care clinicians, HRT Troubleshooting. Millie's on hand from the Training Hub if you have any technical issues, so please reach out to her in the chat if you need any help. The session's being recorded and you'll be emailed a copy of the slides as well as a resource sheet later on with lots of links for both you and for your patients. There'll also be a feedback form sent out. Please fill this in if you can spare a couple of minutes because it's so helpful for planning future events. And I'm really pleased to be joined today by Sharon Hartman. She's a specialist nurse in contraception, menopause and sexual health, a nurse prescriber, and has loads of experience in menopause care. So Sharon's going to be monitoring the chat as we go, responding to any of your questions and queries, and expanding on different themes that I'm presenting about today. So we'd love to make this quite interactive. Please post anything in the chat that you want any more clarification on or any more if you have any ideas. Right, let's make a start. So firstly, just a note on language. Although I'll be referring to women today, all of the information applies to anyone experiencing menopause, whether or not they identify as a woman. So we're really hoping that today's session is going to be really practical, that there'll be some things you can put into practice from this afternoon. I'm going to basically share with you some frameworks on how to approach some common clinical presentations in primary care. The advice is all based on British Menopause Society guidance, and we'll share lots of links for you to read more in detail about that guidance if you want to. So these are the sorts of clinical presentations that we're going to look at. So we're going to work through some scenarios and then talk about a framework for each one. So I'm going to start with Amanda. So she's 47 and she presented to one of your GP colleagues 3 months ago with a classical perimenopause picture, a change in her menstrual cycle, some anxiety, poor sleep, poor short-term memory and some word-finding difficulties. She decided to start on Lenzetto, 2 sprays a day, and some micronized progesterone, 200 milligrams in that cyclical regime, 2 weeks on, 2 weeks off. And she's booked for her 3-month review, and actually, she's really fed up. She doesn't feel any different. And her friends all told her how great they felt on HRT, so she's feeling really disappointed. So have a little think. What would your approach be in this sort of situation? What sort of things would you consider? So for me, if I'm approaching a consultation when HRT doesn't seem to have helped, firstly, I start by thinking about somebody's kind of lifestyle factors and the diagnosis itself. So am I treating the right condition? Some of the symptoms of perimenopause overlap with lots of other health conditions. And so especially if the main symptoms are perhaps mood-related change, fatigue, then really inquiring about lifestyle and work stress, for example, can be really important. If you're confident of the diagnosis, and HRT seems to be appropriate management, but it just doesn't seem to be doing the trick, then I think of the 3 Ds, the dose, the duration, and the drug. So in terms of the dose, we know different women can need different dosages to get the same effect. Some women need really quite high doses, for example in POI, to be able to get that symptom relief. The duration can be tricky too because symptoms can improve at different timescales. Things like hot flushes and night sweats may respond within a couple of weeks, but other symptoms, particularly things like anxiety or mood-related change, may take 3 months or so. And then urogenital symptoms can take up to a year to improve sometimes. And then in terms of the drug, we tend to think about the type of HRT we're using and also the route of administration. Different brands can give different absorption levels, and people absorb different products in different ways. Some women don't absorb so well through the skin, and so they may be using a really good dose of HRT, complying perfectly, and just not getting that response because their body's not absorbing as much as somebody else using the same medication. So coming back to Amanda, Well, when you chat to her, actually, yeah, she is having a really tricky time at work. She's feeling really unsupported, and she's planning on speaking to her line manager. And she's noticed that her sleep and anxiety do seem to be worse around her work days. So that may be part of the picture. When you talk about her dose, the duration, the drug, well, she acknowledges that actually her memory's not been so good and she's often been forgetting to apply the spray. So a couple of times a week, she's forgotten to use it. So she decides maybe she'll try the patch instead. And you talk about using an alarm on her mobile to support that twice weekly patch change to get into that good routine. So that's our first case. Sharon, anything you want to pick up on? Anything from the chat?
I normally ask people when they're applying the spray where they're actually putting it, and make sure that they're applying it correctly, and then they're not using any products on their skin prior to actually applying it. But also that if they are using it, that they're only using the 56 sprays and then setting aside that canister. Because some people, when they're using it, they'll use the spray and then carry on because they think that there's more solution in there. But and it does sound like there is still more product left in the spray, but it does have to be set aside after the 56 spray doses, because otherwise it's placebo thereon after.
Yeah, I think that's a really good point. I've had that as well, where people have carried on with the spray and said, well, it was great at the beginning, and then it just seemed to stop working. And then you work out that, yes, they're using an empty canister. Yeah.
And also, I think that the dose of 2 sprays is actually quite a low dose.
Yeah.
So I don't know whether you, Sam, sometimes say to people when they're starting off and they've got their 3 months, whether after 4 to 6 weeks they do a body check to see how am I feeling now. Because I often do that with people, because 3 months can seem an awful long time to wait for a review and feel like you're stuck somewhere. So for those people that have got a really good rhythm, because you can actually mark the box, can't you, for the 56 day, 56 sprays. And if they're using those tools as well, but they're not really seeing an improvement, maybe after 4 to 6 weeks, they could increase the spray, maybe 2 in the morning, 1 in the evening, and see if that actually helps. Obviously, that has to be sort of, sort of based on what the patient sort of like can cope with, sort of managing themselves as well.
Yeah, absolutely. I think we have to be quite conscious that we want to try and get people to only adjust their dose in conjunction with this, especially with the need now to be increasing the progesterone with these estrogen methods. There is a bit of self-prescribing, isn't there, sometimes with HRT, where people just start taking all sorts of different dosages.
I think you have to sort of be really clear and sort of read your patient well, but if they are sort of like pretty together, you can offer them up to a moderate amount without worrying about the sort of dose adjustments for progesterone. So and I don't know if people know that there's a really good tool on the BMS for tools for prescribing, with a really good grid on what products are considered low dose, moderate or high dose, because that's really helped me over the years.
Yeah, great, thank you. Laura, did you have a question you wanted to ask?
Yeah, you mentioned about 20% of people not absorbing topical estrogen, and estradiol might have a place there. So I know we see the private menopause specialists doing that a lot, and I've done it a couple of times, but don't have very much experience. I'm on Menopause Cafe and kind of use that as a bit of guidance for it, but didn't know whether you had any good guidance and how much GPs or primary care should be doing that, or not really.
Yeah, I mean, I certainly don't think we need to do it routinely, but I think there are occasions where, if somebody hasn't responded at all to, say, a 75 mic patch, 3 pumps of gel, if they've really not got any response, and you do a level and actually it's really low, it can help you then in terms of your management. So I wouldn't do it, I probably wouldn't do it at the 3-month review. I wouldn't do it the vast majority of the time. But on occasion, it can be really useful to guide you in terms of what's happening, as to either to be increasing up on the dose, and we'll come back to that a bit later on, or be thinking about changing product. Of course, pragmatically, you may just want to try something different. In conjunction with the patient, you may decide just to try an alternative. But if that particular product actually really suits them and that's the one they want to be using, if you do have a low level, then it can guide you of thinking, right, well, actually, in this situation, perhaps I do need to go above the licensed dose to get her the symptom relief that she needs.
Thank you.
Lovely. Well, let's move on to our next case. There'll be plenty of time for more questions later on if there's other things that have cropped up. So in this case, Bhavna, who's 61, she's booked in for a medication review. She had a diagnosis of breast cancer 9 years ago now and is on tamoxifen treatment. And at the end of the consult, she says, oh, by the way, could you just prescribe me some treatment for my recurrent thrush? So again, we'll have a little think, what might come to mind in your assessment of Bhavna, bearing in mind this is an HRT webinar. So really, this is around thinking about the genitourinary syndrome of the menopause. And actually, when you talk to Bhavna, she doesn't have that sort of itchy white discharge that might be typical of thrush. And you know that women who are presenting with recurrent thrush around menopause could be experiencing the genitourinary syndrome of menopause. So you can ask a bit more about her symptoms, the impact they're having on her life and on her sexual life as well. And I think it's really important for us to try and be quite proactive about asking about libido, about sex. Often women really want to talk to us about this, but can find it really difficult to bring it up themselves. So our proactive approach can be really important. You may want to offer an examination. Really important to talk about vulval care. And in Bhavna's case, she's always washed with soap. She hasn't changed anything, but she is washing with soap regularly. So you can talk around stopping that and switching to an emollient instead. And then we come on to thinking then about local estrogen. And traditionally, we've often been quite worried about using local estrogen alongside tamoxifen. This is something that we can look at introducing in primary care. We'll all have different levels of confidence and experience in doing so. But for example, we know that local estrogen is fine to use alongside tamoxifen, or if somebody isn't on any active treatment for their breast cancer. We certainly, as GPs, wouldn't be wanting to prescribe alongside aromatase inhibitors. If somebody's on something like anastrozole, it's really trying to suppress estrogen to 0, so we don't want to increase that at all. But there's a JAMA paper now. The link here is on the slide, a really large cohort study showing no evidence of increased breast cancer mortality in patients using vaginal estrogen therapy. So this is something that we can consider introducing. Many patients can be worried, and of course we can be worried sometimes as well. And we're lucky in this area, we've got the Menopause Oncology Clinic with their MDT approach, who are able to see any women who are using anti-estrogen therapy who have menopausal symptoms. So if you don't feel confident yourself prescribing, that can be a really good route to consider. But again, it's really important to think about the basics, remembering vulval care. The Yes range is a fantastic range of products. You can get free samples as healthcare professionals that you can give to patients to try. And also remembering, of course, there can be other diagnoses too. So remembering the value of examination, looking out for other conditions as well. So anything that anybody wants to pick up on with Bhavna's case there? Anything you want to mention, Sharon, to expand on with that one?
No, I just normally talk to people about emollient use and the sort of avoiding anything with any soap-based products or lather. Just exactly what you said, and really sort of encouraging people to try different products from the Yes range for moisturising regularly as well.
Yeah.
And obviously sort of the localised estrogen products.
Yeah. It's amazing what some people use on their vulvas, isn't it? It's quite incredible sometimes when you ask. It is important to ask.
Yeah. I think a lot of women do appreciate if you suggest that they come in and see you, and then you can actually examine them and talk through it, and actually really sort of work out what the problem is, and reminding them that they can use lube as well for any sexual activity.
Super, thank you. So the next case is Cherry. She's 46 and she's come along for an HRT review and she's really happy with her symptom control. It's working beautifully for her, but she's feeling quite worried because she's been getting some bleeding and she's heard that bleeding could potentially be serious and she's really concerned that you're going to stop her HRT. So you may well be aware of a recent new piece of guidance from the British Menopause Society. It's been awaited for quite some time. It's nearly 50 pages long, but there are a few useful summary sheets at the beginning. But it's a really useful resource. It's very in-depth. And this is a flowchart that's taken from this guideline, which essentially helps, again, to give us that framework of what to be thinking about, who we need to worry about in terms of bleeding on HRT. So as you can see at the top of this flowchart here, it's using patient risk factors for endometrial cancer as being really one of the key factors in the decision making. And I'll explore these risk factors a bit more on the next slide. Alongside that, it's reviewing the type of bleeding somebody's having. So we're going to be much more worried about heavy and persistent bleeding than we are about a light and frequent spotting sort of bleed. And also the timescale, how long that bleeding's been going on for, particularly relating to when the HRT was started. So this is a really helpful chart to kind of help us understand when we should be thinking about the 2-week wait pathway, when to be thinking about a scan, when to be thinking about optimizing somebody's HRT to try and see if we can manage the bleeding without necessarily looking at more investigations. So it's literally just been published in the last couple of weeks. It's likely that the local guidelines will be updated now alongside this. So I expect there'll be changes that will come sort of fairly soon in terms of our referral pathways. But a useful framework. In terms of the risk factors, BMI is really key. So from that flowchart, one major risk factor or 3 minor risk factors would indicate a 2-week wait referral. 2 minor risk factors would indicate an urgent ultrasound referral. Lynch syndrome is the hereditary non-polyposis colorectal cancer. I hadn't heard of Cowden syndrome, I had to look that one up. It's a rare condition associated with multiple sort of hamartomas, benign swellings, and a learning disability. It sounds like it's very uncommon. And then the other major risk factors really are relating to how we're using HRT and different types of HRT. And again, I think particularly for us in primary care, especially if we're prescribing estrogen and progestogen separately, really kind of inquiring a little bit with women around how they're using, for example, their utrogestan, how often they're forgetting it, looking to see whether they've been on a sequential HRT for more than 5 years, which is considered a major risk factor. Looking for those expired Mirenas that are always kicking around. So really kind of having that degree of inquiry to understand how much to sort of risk stratify somebody in front of you. And then we can also see with the minor risk factors, we've got PCOS and we've got diabetes. So in some practices, we're probably going to see quite a number of patients who are going to fall into at least the 2 minor risk factors, if we think about BMI 30 and PCOS or diabetes. So whilst the guideline may well help us to stratify a little bit, there may also still be a lot of investigations that we're needing to do to be checking out bleeding patterns on HRT. If we are thinking about trying to optimize somebody's HRT regime to try and manage their bleeding, there are a number of different things that we can potentially do. So we may be looking at changing their progestogen, increasing the dose that they're having or the number of days that they're having it for. So for example, with utrogestan going from 100 milligrams to 200 or 200 to 300, or changing that type of regime they're having it for. We might want to change the method of that progestogen delivery. So for example, switching to a Mirena. We might want to change the type of progestogen. So moving from a micronized progesterone like Utrogestan over to a synthetic progestogen in a patch or a tablet. It may be appropriate to add in some local estrogen, especially if there are some local symptoms, can be a cause of bleeding. And on occasion, it might be appropriate to reduce the estrogen dose, and that may help with bleeding too. So there's lots of potential options that it's really going to be down to that individual in front of you as to what feels most appropriate. The oral types of HRT do have a really good reputation as being really good for bleeding control. So the oral progestogens, apart from our micronized progestogens, but of course, oral HRT is associated with risk factors for some people too. So many of the people who perhaps we would prefer to be on transdermal, they may have risk factors for that oral preparation. So not always an easy one to sort out. So in Cherry's case, actually, when you look into things a little bit more with her, well, she saw a nurse practitioner about 8 weeks ago. She had her previous Mirena removed then, had a smear and some swabs taken and a normal exam. Her partner's had a vasectomy, so you're not worried about any pregnancy risk. And it was at that point that she started on micronized progesterone with Utrogestan. She's been taking it really consistently, and she doesn't have any risk factors for endometrial cancer. So as she's in this early time period within this first 3 months, you decide on a monitoring period and ask her to come back if she gets heavy or ongoing bleeding. So I think this guideline is going to take a little bit of getting used to for all of us. It's very meaty, there's a lot in there, but it's a super useful resource, so worth looking at if you haven't had a chance as yet, and we'll link to it with the resource sheet that will be sent out to you later on. Any thoughts, Sharon, about the new guideline?
I would say it takes a lot of time to have a read through, and I think we'll be tabbing it to make sure that it's a quick go-to. I said to Sam before we started, I actually used the page 9 on the assessment of a woman presenting with bleeding, unscheduled bleeding on HRT on a patient, and I found that really useful to have by my side to make sure that I checklisted off everything that I needed to ask her. And I think that's because I was slightly overwhelmed with the new guidance. And thinking, right, how am I going to manage it? And I'm pretty confident on what I'm doing and use like the referral pathway regularly. But I did feel like, oh God, how is this going to affect my time when I'm seeing somebody? And how am I going to be documenting this? And I think that it would be great if, and I had spoken to our practice about putting this on our Ardens template, so you can literally checklist it off as you're going along to make sure that you've sort of gone through everything that you need to do, and it's like, and then a reassurance that it's all there in front of you. And I think there's a little bit of anxiety as well around how you work out what a minor is and a major, because that, and actually the speed at which you then refer people without terrifying them as well.
Yes.
And explaining everything that's going to happen on their journey through what's going to happen next and why it's so important. I think we're sort of people that prescribing Utrogestan or the micronized progesterone are aware that on the whole, above 50 to 75, there is a more unstable experience for women with bleeding. And it can be incredibly frustrating because they can really love the product for the other effects on their sort of like psychological well-being or sleep. And also because it's such a great product for breast health and cardiovascular lipids, people don't necessarily, and they've also heard so much in the media and social media about the quality of micronized progesterone. They don't always want to go on to a synthetic form of progestogen, and obviously a lot of people as well, they would benefit hugely from Mirena cause, but they can have a lot of fear around that or anxiety about fitting it. So so it's a big meaty thing to look through and sort of work out next steps for everyone.
It certainly is. Yeah. Laura, did you have a question?
Yes, sorry, me again. Just interested with that guidance about how other practices are approaching it. So we've initially done a search and going to review all our patients on 100 patches to up there if they're on a suggestion to do that. Obviously, the ones on gels and things, it's trickier because it's free text, and so the searches are tricky. And didn't know whether it's reasonable to do those ad hoc or how other people are approaching it.
Yeah, it is trickier, isn't it? You know, on an automated search to find them, the only way round I could think about it was the number of devices people are requesting, in terms of you can work out how long, you know, a pump or a spray should last, and potentially then kind of ascertain who's using more. Yes, it's, you know, I think it's a really hard one. I imagine some practices might be quite proactive in terms of contacting lots of people. Others might wait for people to come through. I expect there's going to be a whole range of different approaches. I guess it depends in part as to how often you tend to see people. If it's an annual review, that could be a long time, couldn't it, potentially, of potentially having unopposed estrogen. Yes, interested to hear from others as to what your thoughts are.
That's that. Yeah, I'd like to know. Thank you.
Rebecca's got her hand up as well.
Yeah, hi Rebecca.
Hi Sam, nice to see you.
Yeah, you too.
I don't think I understand the question that's just been asked by Laura, and I'm wondering if I'm a few steps back. What's the search that's being asked about? Because there was also the comment made that you made earlier about when we should increase progestogen cover, and I wonder if it's all part of that and I've just missed something in an update.
Yeah, no problem. So there's a slide a bit later on that will pick up on it as well. But essentially, it's matching these higher doses of estrogen with higher doses of progestogen. And one of the things that the guideline has done for us is kind of clarified that as to what counts as high dose estrogen. So if we're on the equivalent of 100 mic patch, 4 pumps of gel, 6 sprays of Lenzetto, the advice is to match that if somebody's using Utrogestan with the higher dose. So 200 instead of 100 and 300 instead of 200. And it's really, the question I think is around how proactive we should be in contacting those women. And it's easy to search, you know, to set up a computer search to find the people on a patch of 100, but much harder to find people using 6 pumps of gel or 6 sprays of Lenzetto, because it's in the free text rather than in your prescription.
Thanks.
Yes, well, if anybody else has any thoughts around that, post them in the chat so we can compare and contrast what we're all going to do. I think it is going to be an interesting one. So yes, we'll come back to bleed to sort of doses a little bit more in a moment. But yeah, so this next case is Farhana, and she's started HRT and actually feels that her mood has been worse since she started. And so she's now wondering actually if she was depressed after all and not perimenopausal, as to what was the cause for her mood change. And so when I'm thinking around kind of troubleshooting side effects of HRT, when I'm beginning somebody on HRT, I tend to discuss potential transient side effects of the 4 Bs: bloating, breasts, bleeding, and the blues. You can tell I like easy ways of remembering things. And I tend to counsel people that those effects might last for around 3 months or so, and usually tend to settle over time. And then with any ongoing side effects, if possible, it's really useful to try and think about whether they might relate to the estrogen or the progestogen. Now, that's much easier if somebody's on a sequential regime, because you can tell if they're getting those effects with the progestogen part of their cycle. Sometimes trickier. Some effects are much more classically related to one hormone than the other. So typically low mood and acne relate more to the progestogen, and typically breast tenderness and nausea, those pregnancy type of effects, relate more to the estrogen. Some things can relate to either. So things like bloating we can see with both. But if you can identify, it can mean that you can be a bit more systematic with your kind of next steps in terms of thinking about adjusting somebody's HRT. In terms of mood specifically, we know that some women have a progesterone sensitivity. Now, sometimes there'll be a history of PMS, PMDD, postnatal depression, and perhaps mood effects with hormonal contraception. And for these women, if they're using a synthetic progestogen as part of their HRT, you might want to switch over to a micronized progesterone or consider an IUS. If their mood has dipped on a micronized progesterone, you could consider off-license using that micronized progesterone vaginally. But I think it is really important that we explain that the progesterone is essential. Sometimes if people are experiencing side effects and they start to recognize those side effects relate to the progesterone, they might choose to stop taking it. They feel great with the estrogen, don't feel so good with the progestogen. So it's really important that we explain that actually this is to protect against cancer. This is a really essential part of their regime, and we really need to work with them to look at what we can do to optimize how to take it. And then, of course, mood changes at perimenopause can be really significant. So we need to take these mood changes really seriously, need to risk assess people, offer really, appropriate support and kind of safety nets that, especially for those women who've had mood-related changes, there can be a lot of anxiety on starting HRT if they're already struggling with their mood and then that dips further. Sometimes, it can be quite a risky situation. So really taking this quite seriously. As we've mentioned already, the body identical HRT is so popular these days. We're seeing kind of so much kind of desire from women to be using these as a kind of first line. There's a lot of kind of hype, but they do certainly seem to suit some women better. There are some medical indications where these products are better. And in my kind of initial history, if I identify somebody as having had PMDD or really severe PMS or lots of side effects with hormonal contraception, I do very often go straight for the micronized progesterone over a synthetic progestogen. Our other medical indications really around those baseline risks for women in terms of breast cancer risk, VTE risk, and cardiovascular risk. So there is certainly a group of women who do seem to benefit more from the micronized progesterones. They're not suitable for soy or peanut allergy, and the capsule in micronized progesterone contains animal products, which will be of importance to some people. And then of the oral preparations, Famoston is often the one that sort of is most suited if people do want to really breast-friendly oral HRT or a lipid-friendly. It's often quite good for mood as well, so that can be quite a good oral one potentially to pick if somebody's preferring that oral route. So in Farhana's case, she did have quite severe PMS and she did experience postnatal depression after the birth of her first child. She tried the combined pill in her early 20s and actually had stopped it because her mood dipped at the time. She's using a sequential patch at the moment, and so it was quite easy to notice that her mood was dipping with that progestogen time. So you explore different ideas with her. She's not very keen on the idea of a coil, but would be happy to try the micronized progesterone alongside an estrogen-only patch. And then if that still didn't seem to do the trick, you could then think about using the Utrogestan vaginally. Super. Any questions, Sharon, or any thoughts?
No, I couldn't really add anything more to that. Sometimes I find that people who, if they try desogestrel to sort of like stop their menstrual cycle, and then you can, that sometimes stabilizes out sometimes the mood dips, if they're not getting any ovulation. But I think that's it. It's tricky to navigate, but it's certainly something that I do look at as well. And then the HRT continuously.
Yeah.
As a microprogesterone.
Yeah. Yeah. And interesting, that's in the guideline as well in terms of managing bleeding, isn't it? Is using desogestrel alongside HRT, sort of hand in hand as being useful. Yeah.
Sometimes I look at what combined pill that they have used and what progesterone has been in there, and then sort of see if it's a different one that would work better for them, like the desogestrel.
Yeah, I think that can be useful. Yeah, and can give them the confidence that you're really having that sort of personal approach as well, that you're listening and hearing what they've said, taking it seriously and trying to adjust based on that rather than just randomly picking something from the list. Yeah. Thank you. So the next case, Davina, who's 55, would like to start testosterone as her friends have all told her it's great for libido. You can see where my inspiration has come from with this one. So, I think in terms of testosterone, there's a lot of variation between practices. And I think regardless of whether you are or aren't happy prescribing, there is still some really useful things that we can think about and still some really useful things that we can do in terms of supporting women around libido. So both in terms of testosterone, both NICE and the British Menopause Society say that we can consider testosterone to support libido after a biopsychosocial approach has excluded other causes. Libido is really complex. There's usually lots of different factors that come together. These books I find both to be really useful, and I very frequently direct women to them in terms of just reading and understanding a bit more about libido. It can be really important just to kind of explore a woman's relationship if she's in one. Is she wanting to have sex? Is she using any medication like SSRIs that might affect libido? So lots of chat, which is difficult because time is extremely pressured and it's a sensitive subject to be discussing, but really trying to think about it quite broadly and holistically, especially if a woman is, for example, has had a cancer diagnosis, or when there's lots of kind of medical complexity, it affects somebody's sexuality, their sexual feelings. In terms of HRT, as I say, even if you don't feel confident introducing testosterone, optimizing somebody's HRT by, for example, if they're currently using an oral estrogen, switching to a transdermal estrogen, that in itself can increase the amount of circulating testosterone by changing the levels of SHBG. So if somebody comes to you and they're on an oral estrogen, changing across to transdermal can be useful by itself, and not everybody will need to use testosterone. I think it's really important to ask about genitourinary symptoms and to be offering local estrogen, talking about things like the use of lubricants. So again, really taking that holistic approach that if somebody's asking about testosterone, just thinking quite broadly. You don't want to be supporting somebody's libido by introducing testosterone and then find that actually they can't have sex anyway because they're too sore, because they've got, really severe vulvovaginal symptoms.
Sam, there's been a question that's asked as well. Do you want to us to discuss it now or at the end?
Should we pick it up at the end of this section? Is that right? Thank you. And then in terms of testosterone itself, the best evidence for it as a treatment is after surgical menopause and in POI, so premature ovarian insufficiency, where both groups can particularly benefit from the addition of testosterone to standard HRT. It can be really supportive for many women outside of those groups as well. When it's used in physiological doses, it seems to be really safe. There can be some side effects that can include some acne, some local hair growth at the site of application, and sometimes some weight gain. As long as we keep levels in the female physiological range, then more serious irreversible side effects are really uncommon. But again, it's something where it can be really useful to kind of talk with women and make sure that they know not to be just self-prescribing and increasing their dose themselves, because we really do need to monitor it and keep those levels in the range. It's applied topically to the lower tummy or the thigh, and usually give it around a 3 to 6 month trial, and about 60–70% of women tend to see a benefit. And then the blood tests are usually repeated after that sort of 3 months or so to check that the levels are in the range. Currently, the evidence from the trial data really is around libido and doesn't show definite evidence on these other areas, so things like cognition and mood and energy levels. But anecdotally, many women report that they do notice these benefits as well. So the trial data at the moment really only supports us introducing it if libido is low, but there are often these extra benefits too. So in Davina's case, she's currently taking an oral estrogen HRT. So you can explain that the first step is to change this to a transdermal estrogen to see if this helps itself. She does have some vulvovaginal symptoms, so you can have a chat about vulval care and starting some local estrogen and using some lubricants as well. And I think we'll all have different, as I say, different kind of confidence and around using testosterone. Some practices may be happy initiating, some may be happy continuing on a shared care pathway. So I think just kind of, letting the patient know at this point in terms of sort of expectations really around what you can do. But I think, as I say, kind of thinking quite broadly, actually, even if you don't prescribe testosterone, there is still a number of things that you can do to support her care. Thanks, Sharon. Do you want to pick up on that question from the chat?
Yeah, so Sarah's said that the patient's been given testim gel by a private clinic. Testim gel is no longer available. Can we change it to other testosterone gel, i.e. test gel? How do we know what is the equivalent dose? Is it okay to carry on prescribing testosterone when private clinic issued it and not the NHS? It's amber on the BNSSG formulary, specialist initiation. And then the patient that Sarah's referring to, she's not post-surgical POI. My understanding, and I actually wrote an advice and guidance to the menopause clinic with Kristen Manley, and said that could I start someone on testosterone because the person was optimized on estrogen and was still struggling with their libido, and they actually responded back saying no. It has to be initiated in secondary care and then set up as a shared care arrangement. And I already am doing my advanced certificate, so I feel quite confident in managing people on initiating testosterone. But my response back from the clinic was it's not set by them, it's set by medicines management and also the sort of directorship of BNSSG. So I don't know if anyone else has had any other different responses, or Sam, you've got a different approach to that.
Yeah, I think there's lots of different things happening at the moment throughout the locality. And I think for me, it with all prescribing decisions, it's down to us as individuals in terms of what we feel confident and competent to do. And we may well have a practice-based decision or a PCN-based decision. I carried out a survey as part of the fellow role a few months back, and there was a really wide variation that some practices aren't prescribing at all. Some are very happy initiating if there are clinicians who have had more experience, and some are happy in terms of following the shared care kind of protocol. My understanding is there is a new application that's gone into the formulary at the moment in terms of hopefully broadening out the criteria. So I think officially at the moment, it is only on the formulary for those groups, a surgical menopause or an earlier menopause. But hopefully that's due to change at some point. There are certainly more women than that who genuinely see a benefit. So it's a bit of a sort of watch this space really in terms of the formulary side. But I don't think there's any right or wrong necessarily. I think it has to be, whenever as an individual, if we sign a prescription, it's our legal responsibility to say that we're happy with the prescription that we've signed. So just like all medications, we've got to be happy with the monitoring and that it's an appropriate prescription. But yes, there is quite an easy way, an easy sort of chart, again, in terms of the equivalence with the different preparations. So we could share something on that in terms of how to swap from one to another, coming back to the question. Great, thank you. So the next case is around supply issues. So Ellie is fed up that yet again, she can't get hold of the HRT that works beautifully for her. So she wonders, well, can I just change to a tablet instead? I'm fed up. This keeps on happening. Takes so much time. I'm going from pharmacy to pharmacy. And there have been so many shortages, haven't there, over the last few years? It's been incredibly frustrating. Lots of extra prescriptions being issued and lots of work for everyone, and lots of time for patients. So just a few thoughts really around shortages and kind of switching. So this is that equivalence chart that we mentioned earlier from the British Menopause Society. So many of our products, there is more than one type, but with some there aren't. So this can act as a bit of a guide. So if you've got somebody on 2 sprays of Lenzetto and you need to change, to a gel or a patch, it gives you a starting point. It's not perfect. It is a guide because different people will respond differently to different types of medication, but it's a good starting point. The BMS do publicise updates to members. They have a kind of page where they go out to all the manufacturers and sort of ask and say, right, well, when are you expecting this to come in? So there is some guidance that you can get from the BMS website. But yes, it seems slightly better at the moment, but don't know how long that will last. And then in terms of the progestogen shortages, so it was really tricky for a time when Utrogestan went out of stock and before we had the Geprotix. Good that we've now got the 2 different micronized progesterones. Hopefully that's a little bit of backup. And then in terms of our other options for the progestogens, so we've obviously got our Mirena coil that some people are really happy to go for and others just aren't. And then we've got our Provera and our norethisterone. So really important to remember that norethisterone does have an increased VTE risk. So for some women, if they've deliberately been started on a micronized progesterone because of that higher background VTE risk, we need to somehow manage to kind of capture that with these switches to know not to switch some people across. And also just to let you know that some of these products aren't covered by the prepayment certificate. So products that aren't licensed for use as part of HRT are not included. And so people were needing to pay an extra charge if they were prescribed norethisterone, for example, for their endometrial protection. But yes, hopefully it's slightly better now because we've got the 2 different micronized progesterones for that group now. This is picking up on those thoughts from earlier on around matching the higher estrogen doses with the higher progesterone doses. So the recent guidance from the BMS has clarified that they count a higher dose as being 4 milligrams of oral, 4 pumps of gel, 100 mic patch, or 6 sprays of Lenzetto. And if somebody is on one of those types of estrogen, then we should match that with a higher dose of progestogen. So if they're using a Utrogestan, going up to from 200 to 300 and from 100 to 200. The link there at the bottom, the progestogens and endometrial protection, again, is a useful resource and covers some more unusual situations, things like what you do after an endometrial ablation, what you do after a hysterectomy for endometriosis. So the kind of the less typical situations where you just think, oh gosh, I'm not quite sure here. That again is a really useful resource document to be aware of that can give you some guidance. So then coming back to Ellie and wondering about changing to a tablet, again, we've got some medical indications that would lead me to prefer to prescribe a transdermal estrogen over an oral estrogen. So age over 60, migraine, a higher body mass index, a higher clot risk or cardiovascular risk, liver and gallbladder disease, being hypothyroid on thyroxine, and having any GI conditions that might affect the absorption of an oral medication would be potential factors to be thinking around. So in Ellie's case, well, actually, she's been using 4 pumps of estrogel and 100 milligrams of Utrogestan on a continuous combined basis, so taking that every day. Her BMI is 34. So you can advise her that actually with age 62, BMI 34, it is probably better that we stick to that transdermal route if possible. And so she opts to think about a patch instead. And so you kind of can check on those equivalence charts and look at the supply updates and pick an appropriate patch. As we've picked up on already, you've noticed that actually she's on a high dose estrogen and she's got some risk factors for endometrial cancer. So you can advise about increasing up the utrogestan to 200 milligrams each night. And then probably also worth checking to see if she's been having any bleeding, because if she has, she would be somebody who would count as needing a 2-week referral. The numbers of people who bleed on continuous combined regimes is actually quite high. So once you start asking proactively, you find quite a few women who are getting bleeding on a fairly regular basis, who perhaps have just got used to it or just expect it. So there's a lot of bleeding out there. So again, potentially a lot of work in terms of these checks and investigations. Oh, you're on mute, Sharon.
So sorry. Someone's written in, is Mirena coil enough progesterone on high dose estrogen in its 5th year?
Yes,
yeah.
It is. Yes,
yeah.
Brilliant. So it gives us, lovely endometrial protection at any dose of estrogen. I think I do sometimes advise an earlier change if somebody has first developed bleeding in that 5th year. So if it's kind of held their endometrium all the way through and then they newly develop bleeding, I would sometimes think about changing it earlier. But yes, officially it does give that protection all the way through the 5 years.
And also Alison's asked moderate dose estrogen, 3 pumps, 4 to 5 sprays, 75 microgram patch, etc., including progesterone or not, as BMS guidance suggests we do. I'm not sure if I completely understand.
So whether to increase at a moderate dose, yeah.
Increase progesterone, or not.
Yeah.
So on the moderate dose, it's actually okay to keep on the sort of regulated, the regulated sort of dose of 100 milligram utrogestan or 200 sequentially.
But yes, I do sometimes increase it again if they're getting irregular bleeding. So obviously we might need to investigate. But yes, if that dose of utrogestan isn't stabilizing the endometrium, potentially at any dose, you can try and increase to see if it will hold the endometrium better. Yeah.
And Ruth has asked, so you'd increase the progesterone dose once they get to the high estrogen dose you mentioned, rather than over those levels? Yeah, that's
yes. Yeah, exactly.
Needed to say 4 pumps rather than once they go over. Yeah, because we're trying to aim for people to stay within the sort of licensed dosing, unless for special circumstances.
Yeah. Fantastic. Lovely. So yes, this next case is around exactly that, thinking about these very high doses that some people are using. So Hannah is 42 and asks you whether you can continue her private prescription for 8 pumps a day of her estrogel. So again, as we've said already, I'm not here to get anybody to do anything they're not comfortable doing. What I'm really going to do is just talk around a framework as to how to approach whether somebody needs 8 pumps of gel a day. So I'm not going to go through the politics of the sort of NHS private interface. But yes, higher than licensed doses. So I very rarely prescribe above the licensed doses, but on occasion I do. So there are some people who do genuinely need higher than the licensed dose to get symptom relief. So particularly those women with POI and also sometimes after surgical menopause. As we've already mentioned, it's always worth going back to basics. So, if somebody's using a patch, is it sticking? Are they using it in the right way and in the right place? If they're using a gel, are they letting it be absorbed into the skin? Have they got really bad eczema? Is there something else that's affecting that absorption? So just going through, spending a bit of time understanding how somebody is using their HRT is really useful. And that can help you to know, are they actually needing that 8 pumps, or if they just changed what they were doing, perhaps a lower dose would be fine for them. So really kind of just thinking through what's happening. Have they had blood tests done at any stage looking at their absorption? So as we mentioned, some people don't absorb so well and so need a higher dose to effectively get the same dose as somebody on a licensed dose. So one person's 6 pumps might be equivalent to somebody else's 2 or 3 pumps in terms of what they're actually absorbing and getting. So that's where those occasions of the blood tests sometimes can be helpful. And at this dose, 8 pumps, I really want to be confident that she's got adequate endometrial protection. That's a very high dose. So we've got these potential concerns around unopposed estrogen and that risk of endometrial cancer. So really just checking out what she's using for endometrial protection. And there's this concept of tachyphylaxis with HRT. So some women using really high doses can have tachyphylaxis where essentially they continue to get symptoms with higher and higher doses, despite having actually high levels. So again, this can be another occasion where blood tests sometimes can be useful to guide you in not continuing to increase. So some women might have levels of 900, 1,000, but still be having lots of symptoms suggesting that they perhaps need to have more HRT. So again, a useful sort of time where blood tests on occasion can be helpful. So in Hannah's case, actually, she had a surgical menopause at 38. She tried HRT at standard sort of levels, tried a number of different products, both oral HRT and transdermal HRT, and gradually increased up to this level, which has now finally given her really good symptom control. She's got an in-date Mirena, so we're happy from that endometrial protection point of view. And she had a recent blood test on 8 pumps of 450. And so somebody like Hannah, a younger patient who's experienced surgical menopause, can often have really severe symptoms and need much higher doses to get that symptom control. This link from the BMS, a toolkit around surgical menopause, again, is a really useful resource just to know about. Surgical menopause can be different. It's a different experience. It can be really quite a dramatic plunge into a very, dramatic menopause experience with lots of sudden onset symptoms. So again, useful just to bear that in mind. So again, whether or not you're happy to prescribe a more than licensed dose or not is absolutely at your discretion, but hopefully just a framework to help you explore whether medically it seems an appropriate prescription or not. So again, over to you, Sharon. Anything further on that one at all?
Just putting the link on there.
Oh, great. Thank you.
Sorry. No, I think when it's a younger, and especially surgical menopause is really, really difficult. It's very challenging for people. And also for the recovery of surgery as well, if it's quite new, and looking at it more holistically as well in that respect. And sort of like lifestyle comes into it massively.
Yeah.
But it can be really lots of tweaks and changes. That's what I notice with the patients that I work with on it. So it can be quite time intensive for people, and they get really anxious as well if they're not seeing the improvements that they hope to see. So yeah. Thank
you. I'm conscious of the time, just got one more case, so we'll just go through our last case, conscious that it's 2 o'clock, so do please carry on if you need to go. This final case, so George, she's 58. She asks you whether she needs to stop her HRT because her younger sister has just been diagnosed with breast cancer. So again, quite a common situation, and often a source of worry around prescribing with a family history of breast cancer. So again, my approach in this sort of situation is to just explore that family history first of all, think about the number of people in the family who've been diagnosed and their age at diagnosis. And I tend to just refer back to the NICE guideline to kind of help me ascertain whether they're high risk or moderate risk. And then alongside that, obviously thinking, do they need extra screening depending on their age? So yes, that can be really helpful. And then again, that holistic approach, thinking more broadly, well, actually, what other risk factors might she have? What's her weight? Is she a smoker? Is she drinking much in terms of alcohol? Has she got the protective factors of exercising regularly? And it's quite an old one now, but the Women's Health Concern infographic, that lovely picture, I find really useful to look at with women, just to kind of really show that it's not just all about medication. There's lots of factors that contribute to our breast cancer risk. Now, then for some women, that family history, some women just won't want to be taking HRT. They can be really quite frightened with anything that could potentially affect their risk. So some women might prefer to look at non-hormonal alternatives. And on the next slide, we'll have a look at what some of those can be to support with symptoms. If she does wish to continue with HRT, then thinking about the type of HRT that we're using, again, to try and moderate that risk. So we know that our micronized progesterones, our utrogestan, and also dydrogesterone, that's infamoston, are the lower risk types of progestogen. So thinking around the type of product, using it at a lower dose, potentially using it for a shorter period of time can help to moderate that potential risk. In terms of symptom management for those who can't or don't want to use HRT, it's mainly the vasomotor symptoms that have been kind of looked at in terms of other therapies. The SSRIs are probably by far the most commonly used group of medications. If the woman you're treating has a personal history of breast cancer and is on tamoxifen, just worth remembering that some SSRIs can interact with tamoxifen, so we usually tend to go for venlafaxine. Clonidine is the only licensed medication. I haven't had much luck with it, I say, when I've tried it, and the International Menopause Society now don't recommend it because it has quite a few side effects. Gabapentin and pregabalin, again, potentially can help with vasomotor symptoms and possibly sleep and mood as well. Obviously, both control drugs with their own potential concerns, so again, don't feel like a very easy option. And similarly with oxybutynin, there's some evidence that it can help with vasomotor symptoms, but with the side effect burden as it is, it's often quite tricky for people to use in the longer term. But excitingly, we've hopefully got fezolinetant coming soon. So this is this NK3 antagonist that works directly on the thermostat center in the brain. So it's been approved by the MHRA and is going through NICE at the moment, and hopefully will be an option, particularly for those women with breast cancer, relatively soon. So in George's case, well, she hasn't got any other relatives, so she wouldn't be considered at high risk. She is drinking a fair bit at the moment, and she didn't recognise that was related to an increased breast cancer risk, so that was helpful in her overall decision making. And she decides that actually she's using HRT for much more than just the vasomotor symptoms. So on balance, she feels happy to continue at the moment. Any other questions, Sharon, from the chat at the moment?
No, nothing from the chat.
Great, thank you. So just finishing really with a few just other top tips. We've covered a lot of these already. You can cut patches in half. They have what's called a matrix design, so you can potentially cut them in half. Best to do it on the diagonal in terms of how sticky they are. Estradiol has the least skin reactions of the patches. If you've got somebody who's had sort of skin reactions, it can be worth trying different ones because the adhesive is different in the different patches. You can split a higher gel or spray dose to BD, which can be quite useful because you sometimes run out of body to be applying it to, just using it all at the same time. Lenzetto is great for swimmers. You can swim after only 15 minutes versus 6 hours for the gel, so that's helpful. As we said, Lenzetto doesn't feel empty. It has a tick chart on it to count down those 56 doses. And we talk about this window of opportunity for the protective effects of HRT, which is currently thought to be 10 years for the heart and 5 years for the brain. The local estrogen leaflet is still quite misleading. It says things like you can't use local estrogen if you have hypertension. So I tend to just proactively let people know that it's just not very helpful. You often otherwise get a phone call a bit later on saying, oh, you told me it was safe. And with local estrogen, if somebody has quite severe symptoms, quite safe to use it at that daily dose for 4 weeks instead of 2 weeks. It's very, very low dose. So a year's worth of local estrogen is the same as just one single oral HRT tablet. So we really don't need to worry about using daily local estrogen for a little bit longer. And we can combine them as well using things like Avestin with Vagirex, quite safe to use the two in combination. Couple of newer products just to let you know about. So we've got Bijuve, which is this oral continuous combined HRT that contains Utrogestan. Gina is now available over the counter as a local estrogen for women above the age of 50 whose last period was more than a year ago. Got Intra Rosa, which is this DHEA pessary. Haven't used that yet. The head-to-head studies seem that it's not much more effective actually than just emollient use, so I'm not quite sure on its remit as yet. And then we've also got Clara, which is this contraceptive HRT, it's known as. So it's a combined pill with estradiol. It's amber on the formulary for POI, if somebody needs contraception as well as HRT. And again, we've touched on some of these already, but there's potentially a bit of work for us to think around, particularly with this new guideline that's just come out. So if you're feeling keen or have got some med students working with you, there's a few potential project ideas there for looking at kind of optimizing HRT prescribing in your practice. I think some quite easy ones are finding those sequential HRT that's still going at 54 or that somebody's had for more than 5 years. Thinking about switching from oral HRT at 60, or at least offering a switch and finding those expired Mirenas, as well as then thinking about matching the doses as we've talked about. And there's a move towards thinking about including the progestogen on the prescription for the estrogen only. So, for example, if somebody's on estrogel, sort of putting in the direction 2 pumps daily with a Mirena change due October 25. And that can just save you loads of time. If you're doing a kind of whole bunch of med reviews and you come across an estrogen-only script, it means you don't have to be, looking, well, have they had a hysterectomy? Have they got a Mirena? When was it fitted? So that can be, again, quite a useful sort of pragmatic way of supporting safe prescribing. So we'll send out a resource sheet with lots more resources, all of the links that we've talked about today. But again, just particularly wanted to point you towards this easy read guide from Learning Disability Wales, which supports information for people with learning disability. It's got lots of pictures and things on there. And also these leaflets that have been produced by some colleagues at the university in different languages, again, to support people from different communities within Bristol.
There's a few questions coming, Sam.
Go for it.
Rosemary has asked, what level of estradiol on blood tests would you consider to show adequate absorption? Thanks.
I think it's a really good question, and it's not published anywhere. There isn't a guideline or a document you can find which will tell you. And I think the key is looking at what's working for the person in terms of their symptoms. That's coming back to symptoms. But generally, I'm sort of looking for a level of 350, 400, that sort of ballpark. Postmenopausally, somebody's levels are usually below 100. They're usually 60, 70, that sort of level. A level of 1500 usually is because somebody's had a blood test and used their gel, or they've ovulated and had a kind of background ovulation alongside it. Levels of 800 I'd see to be high. So my ballpark is kind of around 350, 450. Is that what you do as well, Sharon?
Roughly, and it also depends on their age as well.
Yes.
I think.
Yeah.
The sort of older, like the younger the woman is, it tends to be. I know Chris and Manny likes it like around 600 to 800. She finds that's absolutely acceptable. But if it's it's an older person, it can be much lower. Yeah. But it is about symptom control as well. I think that some people get really hooked on what their blood results are, but actually how they're feeling. I think that's really, really important. And then there's another question from Ruth. Is there an age limit to the window of opportunity, the age they should start HRT? And my understanding is within 10 years of the menopause, under the age of 60 is where you're going to get those long-term health benefits of your bone health, heart health, and sort of reducing risk of type 2 diabetes. So that's sort of the optimum, but from my personal experience, it's not to then say that anyone over 60, if they've got enduring symptoms of the menopause, that everything else has been investigated, that they aren't able to try HRT for 3 to 6 months to see if that actually supports their symptoms of menopause, because there is a cohort of women potentially that felt that it was unsafe to use, or told it was unsafe to use HRT, but their menopause symptoms have never resolved despite every effort of everything else, and it's actually their quality of life that we should then be considering. Don't know how you feel about that, Sam, but
I'd absolutely agree. So I think the 10 years and 5 years reflects 10 years from when their natural menopause has happened. So if they went into menopause at 45, you'd be thinking up to 55. So traditionally we tend to think about 60 as being a sort of arbitrary number. I do tend to talk to women if they're wanting to start more than 5 years after their natural menopause. There was a study suggesting that actually the dementia rates might be slightly higher in that group. So we've got these protective effects if we've started within 5 years, but potentially a slightly increased risk if we start beyond that. But absolutely, if they're still symptomatic, we can still very much use it to support symptom control. I tend to go in at quite a low dose and kind of go quite gradually if I'm starting somebody new above the age of 60. But yes, as long as they understand that it's very much for supporting their symptoms and not for cardiovascular protection, I'm very happy to prescribe, absolutely.
And there's also someone else with their hand up as well. If they want to ask a question, is that Jen?
Oh yes, I want to with the sequential HRT, because we're starting so many more women on it, so much younger, and there will be lots of women who we started at 45. They'll do their 5 years, they're then 50, and they might not be postmenopausal. So
I agree.
Are we really going to be switching them at 50 and then have the risks of all the bleeding problems, and then that's all work?
I know. I thought exactly the same. I think we are starting people earlier now than we were, I think, 5 years ago. Probably more and more reason to try and get the perimenopausal group maybe to use a Mirena for that kind of lovely, triple benefits of the contraception and the bleeding management and things as well. But yes, so officially that's what the guideline says. It does say after 45.
Yeah, should we then be counselling about an increased endometrial cancer risk with the sequential HRT? Do you do that?
I haven't done traditionally, but I have usually switched people within 5 years. So I think if they're on sequential and, if their bleeding has settled, if they're not getting much bleeding at all, you can sometimes switch them earlier. Yeah, it's going to be interesting, isn't it? I agree. I think quite a few of those would then bleed if they were switched to continuous combined at 50, if they've started quite early in their perimenopause kind of journey, if you like. Yeah, and I wonder if that's more of the kind of the secondary care, maybe they don't realise that we're kind of doing more a little bit earlier now. I don't know if it's a sort of different approach. It's interesting. Super. Well, I'd better let you all go. Thank you for coming. Thanks for being here. I hope there's been something useful that you can take away and use in your consultations. We've got the next webinar in May, focusing on premature ovarian insufficiency. Again, trying to make it really practical, how to recognise it, kind of primary care management, long-term management, lots of resources and things again. Again, it will be recorded, so if you can't make the live, there'll be a recorded given. So yes, thank you very much, and please fill out the feedback form if you can.